movement, demanding that gender equity. And I know one of the statistics you talk about a lot is globally about 70% of healthcare providers are women, which we all know that. And there are informal providers of care as well as formal paid positions. When you get to the leadership levels, the percentage shrinks from 70% to 40% to 30%, so there aren't enough, I would dare say, women leaders in public health and global health in most countries and around the world. So what are some concrete things we can all do? Thanks.
I was nodding my head because I agreed very much with what's been said on this, amongst women leaders. Of course, I have to agree. I'd say there's so much that can be done, but it is about, women in global health. We use a movement model, collective action, and Laura, you cited our website. We're demanding for that change, and it begins with bold, intentional actions, particularly when it comes to women's leadership in health. When I started Women in Global Health, I was in training myself, internal medicine physician. I still practice at Georgetown University, but it was exactly that question where I was looking in the hallways in my clinical training center and I was seeing women were delivering care, but who was getting celebrated, decorated, and promoted? And often it's the hallways where you see photo after photo of the male chairs. Similarly, I was advocating as a youth at the World Health Assembly, similar building to the one that's across the street, the United Nations. Again, it was male after male. And I wanted to be part of the generation that would see a different reality and not just patiently wait for it, but demand for change. So bold intentional change begins by, acknowledging that women actually, face a bias, a major gender bias. Most women face a motherhood penalty, whether or not you have a child or plan to. You will be perceived as a carer, and that really impacts women in surgery more than any other profession amongst the physician specialties. But we also have to talk about the male bonus, right? It's a male benefit by being perceived as that they will not be carers, that they will not be fathers, that they will not have any care responsibilities. And that must change. And I think it's about acknowledging that aspect. So some of the solutions we're putting forward, we call them bold, is having all female shortlists until you actually get to a place where you've balanced that historical injustice. So it's not that we're saying, give women that are not qualified. We're saying women are qualified, they have the expertise, but they face a bias. And we need to equalize that by using techniques that are proven, quota for affirmative action, or just all female shortlists. And we know that when we have women in leadership, it makes a difference. We've heard about the diversity evidence, just presented here from the state of New York, but this evidence plays out over and over again. When you have health providers, from physicians, nurses, midwives, community health workers, coming from those communities, especially women, it's going to make a difference on the health outcomes. These health disparities we're talking about are gender disparities, but they're also coming with a broader intersectionality lens. So it's not only about the right thing to do, it's about the smart thing to do. And that is the case that we make, is that when women are in leadership, they invest back into their households, into their communities, in education. They also pass laws addressing issues such as sexual harassment, rape, gender-based violence, broader women's health issues. So really getting power into the hands of women must be intentional, and we must do it acknowledging that there are historical injustices that need to be equalized.